Hi, greetings, ladies and gentlemen. My name is Lieutenant Andrew Massiello, and I will be doing my tech talk on adaptive testing and skill sustainment. So a little bit of background. Back in March of this year, I had an opportunity to attend a learning symposium hosted by Marine Corps Training Command for all 26 of its major subordinate formal learning centers. While I was there, I had an opportunity to meet a researcher from the Office of Naval Research who was conducting a study of adaptive testing at the Marine Corps Motor Transport School with one of its engine maintenance courses. And it was at that time I asked them if the Office of Naval Research was evaluating adaptive testing in medicine, to which she responded no. And that conversation kind of remained in the back of my head. And when we received the assignment for this talk, it kind of popped back into my working memory. And so I wanted to discuss adaptive testing, the traditional model of adaptive testing that we probably all share, what research has moved forward with in adaptive testing, and how we can more efficiently employ it and utilize it in healthcare modeling and simulation to better utilize our limited manpower and equipment resources. First, the brief overview of the contents of my presentation. So I'll be doing a brief review of the traditional definition of adaptive testing, as well as an introduction to the most common places that we've likely seen adaptive testing, followed by a discussion of several scholarly journal articles with recent research into the field of adaptive testing and how that concept has evolved. And then finally, I'll take those pearls from those individual studies and provide what I see as a way ahead with adaptive testing within healthcare modeling and simulation and skill sustainment within military medicine. So what I have here is the American Psychological Association's definition of adaptive testing. It's defined as a testing technique designed to adjust to the response characteristics of individual examinees by presenting items of varying difficulty based on the examinee's response to previous items. And the process continues until a stable estimate of ability level of the examinee can be determined. So adaptive testing is most commonly seen in exams such as the GRE and the NCLEX. And what those exams do is they will provide you questions on scaling difficulty. The better you do, you will get more difficult questions. If you get a question wrong, the exam will give you an easier question. If you get that question wrong, easier or similar difficult to scale. If you get those questions right, it'll give you more challenging questions. Something unique to the NCLEX as opposed to the GRE is how the test assesses your performance. When I took the NCLEX, the exam could give you a minimum of 75 questions or up to, I believe it was 250, 260. And what that exam attempted to do was continue to challenge you until it determined that you could, perform as a nurse on day one safely, or you were not safe to do so. And the evaluation schema here is one that is summative, right? It's a final assessment of your ability to perform, specifically in terms of the NCLEX. And even for the GRE as well. These are things that's a snapshot in time of our ability to perform or recall information, make clinical decisions, and respond to a clinical situation. It does not, we don't go back and reassess. We don't take that exam again and see if we, perform similarly or better. In my literature review, I found several studies looking into adaptive testing as a means by which skills mastery is defined by multiple metrics. And these metrics can be a length of time that it takes to obtain a correct answer. It can be the length of time it takes to physically complete a task. It can be the distance that a trainee travels across a training site when accomplishing a task. It can be the accomplishment of steps required to complete a task in a specific order or in the wrong order, but still resulting in the correct answer. And based on the different adaptive testing schema, those schema will assign different weights to these values to essentially create a learner score on How long will it take you to obtain mastery? Or can we predict when we will be able to determine when your skills will depreciate to a point where you are no longer proficient? And if we can do that, can we predict how long it's going to take you to need to perform clinical skills sustainment? Essentially a framework for when you as a clinician need to refresh those skills before those skills decay past a point of safe medical practice. And from a healthcare modeling and simulation standpoint, if we can create a predictor for when, X, Y, and Z clinician or medical professional needs to get back into the sim center to practice a high acuity, low opportunity procedure, we can be there in the right place in the right time for the right learner. We can better target how we employ those tools to maximize patient safety in clinical practice at our facilities. So our first study, published in the journal Military Medicine by Siu et al., employed VR trainers for laparoscopic surgical skills, conducting needle passing and peg transfers. The study designers proposed employing the adaptive control of thought rational, or ACTOR, cognitive architecture to assess skills acquisition based on objective measures from electromyography, or EMG data, collected from participants engaged in skills trainers. Just a brief background, the ACTOR model is focused specifically on the relationships between declarative and procedural memory and the perceptual motor function of employing that memory, or doing the task. It is the study designer's belief that creation of an accurate model of the time taken by study participants to perform a task in comparison to a predicted latency model based on ACTOR data, that it would therefore be equally likely that the ACTOR model could also be employed to assess declarative and procedural knowledge for the maintenance of surgical skills. Data were collected from a total of 5 novices and 4 medical trainees. And given the small sample size for this study, the data are likely limited. And each participant performed 2 basic surgical tasks 5 times in 3 individual sessions, which were again repeated 1 week after baseline and then again 1 month after baseline. EMGs were used to track kinematic data, such as distance traveled within the training space, as well as muscle effort for the completion of the task, as well as accuracy in completing the task. With the data collected by the study leads, they were able to create that projected latency for participants for the peg transfer, as well as the needle pass trainers. Actual time taken to complete the task trainers by the study participants was roughly equal to the projected data for the latency model. And therefore, the study designers conclude that it can be reasonably assumed that a similar model could hold true for the prediction of clinical skills decay. Again, here is the visual representation of the predicted latency for the individual task trainers, followed by the actual time taken by the study participants to complete the tasks. So our next study, published by Hu et al. In the American Journal of Surgery, followed a group of 48 randomly assigned preclinical medical students engaged in 3 different simulation training modules, the first being for basic suturing skills, the second for intubation, and the third for subclavian central venous catheterization. The groups were divided into the QSIM, the adaptive testing, and a volume-based traditional training regimen, or a control group. So the control groups followed, again, a traditional volume-based training regimen where they conducted 7 weekly one-on-one training sessions, roughly totaling close to 9 hours, while the QSIM group engaged in each task until they were deemed proficient by QSIM criteria. Okay? And so success for the QSIM criteria is defined by a curve that trends upward and eventually will cross a defined threshold value of proficiency over a series of attempts, while a series of unsuccessful attempts will kick them over the indicator for substandard performance, thus requiring additional remediation. So again, once they were deemed proficient in a task, they would move on to the next one, followed by the third task. So the study designers hypothesized that while a traditional volume-based training system could convert technical mastery for these skills, They supposed that the CUSUM-guided protocol would attain equivalent results with less overall practice time, which held true based on their results. It actually took several less hours, 20% total less time than for the volume-based group in order for the students to reach mastery by moving past topics that they had reached proficiency in as opposed to being forced to continue to train those skills. The next study that I reviewed was the 2-year follow-up conducted by Hugh and Ramirez et al. To the previously referenced study regarding the CUSUM training schema versus traditional volume-based training for surgical suturing, intubation, and central venous catheter placement. And what they found was a nearly 20% reduction in practice time to teach and reach proficiency. And ultimately, the CUSUM guided training provided equivalency to the traditional training for those interventions, indicating that there was equivalent competency with traditional volume-based training. Furthermore, given that the study designers found that proficiency did not depend on initial training method, your traditional volume-based versus the CUSUM adaptive, this indicates that employment of adaptive testing methodologies can lead to mastery in a more efficient manner than traditional methods. Furthermore, given that the CUSUM method enables the capturing of variability in learning curves and relapses in proficiency on an individual basis that is not as resource intensive as a traditional model, it can be used to better and more efficiently monitor clinicians for the likelihood of surgical performance and associated reduction in morbidity and mortality by capturing folks that dip below the proficiency threshold early and often and remediating them before an adverse outcome can occur. And this has significant implications for us in military medicine, especially as we look at high acuity, low opportunity procedures and how much we need to utilize healthcare modeling and simulation to provide access to training those skills. The next scholarly journal article that I selected was published in Military Medicine by Kelman. In this article, he discusses ARTS, or the Adaptive Response Time-Based Sequencing Adaptive Testing Schema. It's an interactive learning system consisting of learning trials, which use each learner's accuracy and speed to guide the sequencing of individual knowledge components leading to mastery, while it applies a priority scoring system to learning items. This priority scoring system utilizes response time and the procedural combinations required in specific medical interventions. Furthermore, it optimizes learning by addressing several items simultaneously in a priority scoring system. And these scores are updated after every trial as a function of learners' accuracy and their response times in the number of trials that they've participated in view of what defines mastery for that specific skill. Finally, I selected a publication from the Journal of Cognitive Science on which Dr. Kelman participated in as an author. In this study, they conducted 2 experiments employing the ARTS system with volunteers from UCLA. In these experiments described in this study, they evaluate the effect of dropout for the removal of content that has been determined to have been mastered from a quiz bank, in order to more efficiently utilize learners' time focusing on material that has not yet met mastery criteria. For this study, mastery was defined as 5 correct responses to a question when presented in a row. Study participants were provided a map to the continent of Africa and asked to correctly identify 24 countries. In the first experiment, which compared the adaptive ARTS group to a random control group with no dropout, the adaptive spacing for the ARTS group proved to be better retention for material than the random presentation group. And this was displayed in both immediate and delayed post-tests, and there was additionally a better learning efficiency in the arts group than there was in the randomized group. Well, the second experiment compared the adaptive arts group, their performance to the random group, but this time providing that random group with dropout of mastered content. Again, the methodology proved the same as the first study, as the learning efficiency remained greater in the adaptive group than it did in the random group. And again, the adaptive group performed better than the random group in the second post-test. So to reiterate my earlier point, adaptive testing is growing as a field that may very well provide an incredibly invaluable tool for us as healthcare educators to more efficiently and effectively target our limited simulation and modeling resources to learners who need them the most for the procedures that they need them for the most. Additionally, the use of cognitive models to predict adverse outcomes from surgical procedures as a result of cognitive skills decline could possibly be in of itself predictive of sentinel events. And it may have a direct outcome, positive outcome on patients. Given that models such as QSUM and ACTOR have that potential to provide those predictive models for provider performance, it really could be an invaluable tool for maintaining an accurate inventory of clinicians throughout the Department of Defense, given further research. And furthermore, ladies and gentlemen, I just want to thank you again for your time and for your attention. I hope that you have found some of these concepts that I've discussed today to be just as fascinating as I do. I really hope that, our community of healthcare educators can hopefully begin to leverage some of these adaptive testing schemas, these adaptive testing models to create a better longitudinal assessment of the performance of ourselves and our peers. Thank you again for your time.